So we evaluate AMD based on symptoms from the patient. If they complain of distortion of vision in one eye or difficulty with reading, then we normally carry out an examination and then an OCT scan of the back of the eye. And we're looking for evidence of disruption of the outer layers of the retina in the central area of the back of the eye that we use for reading to be able to diagnose the condition. We typically divide the condition into wet and dry forms of macular degeneration, and it's really important to diagnose the wet form, which results in abnormal blood vessels growing into the retina and causing leakage and bleeding, as this can be treated with injection therapy if we pick it up early enough. Currently, there's unfortunately no effective treatment for the dry type of macular degeneration. So we know that patients who have a family history of AMD are at increased risk, and we also know that smoking can increase your risk. But many patients also develop what's called drusen deposits at the back of their eye, which are like little small lumps of a waste product that builds up just underneath the retina. These can predispose the eye to developing what we call wet AMD, which then causes increased distortion of your vision. We often give patients with this an Amsler grid so they can monitor their eyes separately for any distortion of vision. And we ask them to see their ophthalmologist quite promptly if they notice any change in their vision while checking this grid. So if AMD is left untreated, it can result in permanent scarring at the back of the eye, and you can actually lose your central vision. It rarely affects the side vision though, but it can affect reading and ability to recognize faces. So we currently use anti-VEGF injection treatment, which is the best treatment for wet macular degeneration, as it can help the abnormal blood vessels stop bleeding and leaking at the back of the eye. Currently, we use ranibizumab or aflibercept or the newer faricimab injection treatments, as they are licensed for the use into the back of the eye, and they're approved by NICE. And these injections, although they sound quite scary, they're actually quite quick and simple to deliver into the back of the eye with minimal discomfort. They usually cause a bit of grittiness for about 24 hours, but most patients can get back to a normal routine the following day. The downside, however, is they have to be given quite regularly, and initially we have to give them monthly, and they need to be carried on for at least a few years to give the best outcome. So several patients need many injections for several years, and initially they start monthly, and then they can be reduced to sometimes 2 monthly or 3 monthly. But the eye seems to tolerate these very well. The frequency usually goes down over time as the fluid and the leakage reduces, and the risk of any severe infection or problems following the injections are usually very low. So not usually in AMD, as anti-VEGF agents such as ranibizumab, aflibercept, and faricimab are the only really licensed drugs to be used in AMD currently. We only use steroid injections for other conditions like diabetic maculopathy or retinal vein occlusions, where we predominantly use these where the anti-VEGFs are ineffective. But currently, the anti-VEGF agents are really the only treatment we can use in wet AMD.